Okay, good morning, viewers. Welcome back to another episode of Monitor Your Health, the program where we enlighten the public on common health situations. Today, we're going to talk about an important topic, breasts. We're going to talk about breasts. It's all about breasts today. And I have with me here a capable doctor that I know will be the one that can do justice to this. Just before we go into that, my name remains Dr. Femi Ogunremi, and I will be your host for today. I'd like to welcome Dr. Hazem Khout. Welcome, Dr. Hazem.
Morning. Hiya.
Hi. Thank you so much. I know you're very busy. You're a very busy surgeon dealing with breasts all over the place. For me to drag you here, I really thank you so much. So today we're talking about breast. Please, can my audience or our audience, can they meet you?
Right. So good morning. Thank you very much, Femi, Dr. Femi, for giving me this opportunity to meet with colleagues and also with families and members in Nigeria and everywhere. My name is Mr. Khout. We say here Mr. for the surgeon. So my name is Hazem. I'm a breast surgeon. I'm specialized in breast cancer. But also I deal with benign breast problems and also cosmetic breast issues. Beside my work, I work in Nottingham Breast Institute, which is one of the largest units in the UK. And I've been working in the unit for 5 years. I've been a consultant for almost 7 years, but working in this unit for 5 years. Beside my work, I also do what we call it the QA surgeon. So looking for the quality of a breast service in the East Midlands, which is a large area in the UK, covering about 9 breast units, doing regular visits and to see whether the surgery, whether the investigations, everything being done according to the standards. So I hope that I'll be able to answer some of the questions, and if we have any trainees here, I also work as a tutor for the Royal College of Surgeons of Edinburgh. Well, the regional advisor for Nottingham.
Thank you so much. That's a very big CV. Thank you. So, right, if we go into it, how common are breast problems?
So the breast problems are very, very, very common. I mean, if you put the breast, people, when you say breast problems, the first thing jump in the mind is breast cancers, which is not correct. The breast problems are benign problems, and also some physiological issues beside the breast cancers, which is the main, worry for all the ladies, I would expect. It's very common. Half of the, populations are female ladies. So, but also even with a male, you do get breast cancer in men, and you do get also very common benign problems with men like gynecomastia, which means enlargement of the breast tissue in men. So all in all, it's very common. And if you look at the family history doctors, and Dr. Femi is one of them, you see plenty of patients, many of these patients come into your clinic with different presentations and with different complaints and problems. As we know, the breast as an organ is designed to get affected by hormone, and as part of this effects to get fluctuate during the life, but also in the same time, with anxiety, with worry, with stress, etc. You get different.
Carry on.
Yeah, you get different. You get different symptoms. The main one is maybe the pain. So it's very common problem we see. If we concentrate on breast cancer, it's probably the largest killer, if you want, among cancers in females, which is a worry, and it is still actually a worry. And I remember when I was medical student many years ago, we used to be taught that it's 1 in about 12 or 1 in 11. So every 12 lady or every 11 lady, one of them will have breast cancer at some time in their life. Now we teach the medical student it's 1 in 8. So actually it's getting more common now, probably because of the environment and what we're doing for the environment, and the pollution, etc. Probably the way that we eat, probably the way that we behave, probably a bit of all what we said altogether.
Mm.
So it is very common, and we always ask the ladies to be aware of the breast issues and problems.
Mm. Right. Okay, thank you so much there. So it sounds more like something that is really, really common, and we need to be very much aware of it. And then I think it's similar here when we look at even developing countries, we're now having a kind of rise in the number. And just similar to what you just said, we believe that because we're now imbibing, the culture, the Western culture, and then kind of the thing we eat, some environmental factors, and the fact that even the social cultural issues here, like ladies now, in those days, it used to be that ladies will, they get married quite early. So now people delay, getting married, having their children. And I think this seems to be some of the things that we're noticing here in this part of the world that is also increasing the number. Right, thank you. So in terms of the presentation, what are the things that you see in breast clinic that make you, sort of worry about, or what are the sort of symptoms that people present with that you see?
Yeah. So I'll start with the symptoms, and to be honest, I'll start with the very, very common symptoms. So if you put them, the most common symptoms are ladies come in with pain, or come in with lump, or come in with pain that is with a lump. So painful lump. So these three, if we say these three, probably we are covering almost about 80% of the of the presentations. But we also see things like, nipple discharge, nipple changes, skin changes. So, like an inversion of the nipple going inside, and then other things which are less common, but these are the most common symptoms. So if you take the pain, for example, it's probably the most common presentation in the UK in the breast units. I can't put percentage, but I would probably say at least 60% of our patients will come with pain. And the majority of the time, pain by itself is most likely, not always, but most likely is benign.
Right.
So we're not worried about pain itself. We do the investigations, and I'm going to talk about what we do here. And obviously it's different. We go different part of the world, and it's different way they tackle the same problem, because your challenges are different from the challenges in the UK, that are different from the challenges in America, different challenges in different part of Europe as well, or the Middle East, or different part of Africa. Yeah. So as I said, the pain is the most common probably. Next would be the lump.
Right.
And with a lump, the most important thing with a lump is we ask the ladies how long the lump been there. And it's a very common thing, especially I would say in developing countries, where the ladies try not to examine themselves altogether because they worry if they examine themselves, they might find something, which sounds a bit, not logic, because what you want is actually to catch anything as early as you can. So when the patient come to me and say, I had this lump, I examine myself every month, and this is definitely something new, and this is definitely for the last week, the first thing comes in my mind is benign things, like cysts, things that not worrying. Cancers do not appear overnight. Cancer grow up slowly and creep and become bigger and bigger and bigger with the lady neglecting them. And then you have again the pain with a lump. Again, if the lump is painful, most likely is something like a cyst, or even sometimes like benign changes, hormonal changes. As I said to you, breast is designed to get affected by hormone. That's part of the breast function. So it's very common to see, let's say, the 20-something-year-old lady going through exam, or her mum going through like hardship, or her grandfather is a bit ill, and she start worrying and anxiety, and that as part of this change in the hormones, they start feeling some thickening. I wouldn't call it a lump, thickening in the breast, and sometimes even with soreness. A very common question. So if the pain is hormonal most of the time, why the pain comes in one side? It's actually 90% of hormone-induced pain, breast pain, comes in one side. It doesn't make sense, but this is, mama nature. It's different, one side is more susceptible, if you want, to the pain than the other side. So again, these are the common things. And then when we start worrying about breast cancer, I would start first if I see a lump which is quite hard, like solid, like a rock, yeah? But not always has to be like rock. Sometimes it's a bit like, softy. I would definitely worry if it's attached to the skin, so it's quite like stuck to the skin, or stuck to the muscle underneath, so it's quite deep and I can't move it easily. I would worry with the age. So again, we used to say 50 and older, but now I would probably say 35 and older. Yeah. Common things are common in ladies who are younger than 35. It's unlikely to be cancer, but you always have to be checked before you reassure yourself, I'm young enough not to have a cancer. The other thing that makes us worry about breast cancer is nipple discharge, and especially bloody nipple discharge. I have to say, even with a bloody nipple discharge, the majority of the time, the cause is benign. Okay, so it's unlike what you think. If you see blood in a discharge, don't ignore it, but the majority of the time is something benign. In a small proportion of ladies, maybe 5 out of 100, so 5%, this might be presenting a breast cancer, or maybe less than 5%. Yeah. And then the other thing is nipple retraction or inversion. Again, it's very common, and it can be very physiological, especially ladies who just gave birth and, breastfed, and the stopped breastfeeding, the breast gone down, and the central part of the breast went down more than the peripheral part. And as a result, the nipple is being pulled in. Again, we start worrying about the nipple inversion when we start feeling something behind the nipple. So if there is something there, a lump that is pulling the nipple inside, this is what we worry about. These are the most common, if you want, presentations, covering benign and also covering the cancer ones.
Wow. Okay. Thank you so much. So now, in all this, I know you've tried to break them down quite explicitly for us. I think one thing that might be pondering in people's mind is, yes, people come with all this, and then yes, we think they're not benign and they're not cancerous or a cancer situation. At what point do you get worried, or what are the signs that you see that make you then worry about, this is likely to be breast cancer, or things that get you worried in that sphere?
As I said, definitely a hard mass fixed to the muscle or fixed to the skin, right, and sometimes start protruding to the skin, ulcerating. Unfortunately, I've seen some ladies with, ulcer on the skin with a lump behind, and they're treating it as a chronic infection, which is not a chronic infection at all. And they should have been seeing these specialists earlier than that. I would worry when I see a nipple inversion or retraction, but with a lump behind it, pulling it inside with nipple discharge, like blood discharge. These are the very, worrying for me. And especially if the lady says that she doesn't examine herself frequently.
Right. Okay.
Because we have no idea whether these being, acute, like, just being a matter of few weeks, or is it something been growing for months and months?
Yes. Okay. All right. So I know in the UK, things are quite structured, in terms of picking this patient early, because I'm sure there'll be some surgeons watching now, maybe Nigeria or in some part of Africa. And I know there are a lot of things that we see here that, I'm in Nigeria as I speak with you. And then in Nigeria, there are things that people see here that you can't just believe it, to be honest. Purely because ladies present quite late. So all these signs, symptoms that we talk about, often it's such that, you pick them early there, probably because of the screening or things. Can you just tell us what sort of screening program do we run in the UK?
Yeah, so I'll go through the system here. So first of all, you can have like two parallel systems. The first one is the acute or symptomatic, which means if the lady feels something or have any complaint, she goes to her family history doctor, a GP. We call it a general practitioner here. And then the GP will examine, and if he's still worried or, concern or he wants to clarify what the symptoms are, then they send the patient to a breast clinic. The breast clinics here run what we call it one-stop breast clinic, which is brilliant because the lady doesn't have to go for multiple visits to see different specialists. What would happen? She would come, she would see a specialist, most of the time a surgeon. In the UK, it's a surgeon, to be honest, a general surgeon that specializes in breast.
Yeah.
They would take the history, they would examine the patient, and then from then they will ask for mammogram or ultrasound scan or both. If there is something there that needs to be biopsied, then the biopsy will be taken at that point, and the lady had the full visit, three parts of the visit all done in the same time, which is the clinical examination, the imaging, and take a biopsy. That is one-stop clinic and very reassuring for the lady, and it's really, really good example. Not many places, unfortunately, have the same example. And then you have the parallel system, which is the screening system. And in the UK, any lady from the age 50 to 70, and now they have introduced in some areas a 1 mammogram before, 1 mammogram after. So that means from age 47 to age 73, they get 1 mammogram every 3 years. The idea is you pick things early. Roughly speaking, we see about, for our cancers, about 1/3, maybe 1/4, 1/3 of our cancers are actually coming from the screening. Right. So you can imagine 1/3 of the, 1/3 of the breast cancers are small enough not to be felt by the lady, just being picked on the mammogram, routine mammogram. Now, this is of course fantastic, but there is an infrastructure there. There is, it's a huge program. And if you see the history of how the screening started, not only in the UK, in any other developed country, you would see actually there was a lot of effort. It wasn't like, overnight they said, okay, we're starting tomorrow. It needs a lot of work. And I understand because I do some work in the Middle East as well. And I understand that Africa, maybe Middle East, have some common things in terms of probably some of the ladies' attitude towards going to the clinic and presenting their problems. Probably they are too busy, with their, work, with their community, local places. Probably they have to, travel way, far away to be seen by specialists. And this is why it probably the best thing for the Middle East and the Africa is the self-examination and the awareness, the breast awareness. So the ladies filter themselves, the symptoms. That is the first front line for us. And we need to rely on the patients being, really educated in terms of the breast. I can tell you something funny, Dr. Femi. If you see the ladies here, the current generation, nobody will call it that disease. Back home, I know the majority of the ladies will say, oh, I don't want to talk about that disease, the C word, because they're so worried about, in back home or, I'm sure that in Africa the same, they're worried even about mentioning the name cancer. But when I ask the patient here, their grandmothers, the old generation, 50 years ago, 40 years ago, used to call it that disease, used to be worried about even mention it, used to be worried about taking it to their GP or the general practitioners. I think the natural progression is the more the people know about it, the more we educate our patients. They are educated, but what I'm saying is educate them about how to self-examination, when to seek, help for these problems. And even our general practitioners, the first line in the small villages, to be aware that this is a problem and this is a growing problem. It's not a problem that is, I know it's, if you look at the diabetes problems, the hypertension problems, the heart problems, etc., but the breast cancer can kill patients. Exactly like any other, like untreated hypertension or diabetes or whatever. So I think the first line is the breast awareness, and the breast awareness comes not only from the patients, but also from the doctors, from the front line, and also from the policymakers. The policymakers need to do something to, make awareness of the breast campaigns, the breast cancer campaign, etc., and make it available. The mammograms. Now, I know that I've talked a lot about the system in the UK, and it's as I said, as you said, it's quite rigid, it's quite standardized. when I introduced myself, I talked about my other role as a QA surgeon. So I go to unit and see how the breast screening was carried out, how the patient had the surgery. Did they actually follow the guidelines, the protocols that we have? And that is way advanced, in terms of, it's not just picking the problems, it's also like following the problems all the way to the treatment. And I'm just wondering, as a curiosity, how the things are in Nigeria in terms of the, in screening, in terms of the, self-awareness, all of this stuff.
Yeah, I mean, that's a very deep question, it's, I mean, Nigeria, I've been both sides of the ocean. And when I look at what's going on in Nigeria, there's nothing close to what operates in the UK. I know, just like you mentioned, if I'm in a primary care and I see a lady with, a breast issue in the UK, it's very easy for me to say, okay, after my initial assessment, whether this is something that they need to have a two-way referral or something that, it's just nothing or whatever. But here in Nigeria, it's completely different. There's no structure. That's what I find. There's no structure whatsoever. Both sides of the coin, looking at the professional, that's the doctors or those people dealing with the patient, and when we look at even the patient, the awareness is poor, and I think we have a lot of issues there. I've tried to do a lot of work around breast cancer in Nigeria, using breast eye, which is I think I have one. Yeah, breast eye. This one. It's an infrared based screening tool. We don't have a structural screening system in Nigeria. Mammogram, I remember going to a particular state where the population is about 4 million people plus, and then there's only one mammogram machine that was working in that state. How do we cope with that? So you have people presenting quite late because there's no structure. People coming because they now find things really, scary. So that means they've left it so long. Even when they feel lumps of things, they keep praying about it. We are too religious in this country. People pray a lot. And then apart from praying, they try to go to the traditional healers to try and help them. So they do all these things and delay this process till very late. They now present to the doctors when it's already ulcerating and they can't do anything. So we're picking them at a stage where we just have to do palliative management. So people, even the surgeons are getting fed up. I've spoken to quite a lot of them, surgeons, and they're really, they're having it up to here because they're looking at the way to actually go about it to get people screened. But like you just said, screening is not something that you just start like, oh, I'm screening like that. It has to be a structure. And one thing that I've noticed in Nigeria is a lot of people are trying their best, but there's no policy or people to actually firmly support the ideas that everybody is doing. So you can just find a group of charity. They want to help the people. They will come this year, they screen them. What happens next year? They might not see anything again, even till maybe 5-10 years time. They might be nowhere. So, and it's because people don't understand the processes that is supposed to be involved in putting a structure in place at the simplest form, that can actually help the people. So the bottom line is, in terms of the screening here, I think nothing, basically nothing. We're just trying to just see what we can actually put out there. I'm hoping that the policymakers will be hearing this. Lagos State, during the time when I came in to do some work, I was able to key into some states, like Lagos State keyed into it briefly before the lockdown started. Then Kwara State was a place I did quite a lot. I think we screened about 5,000 ladies, but we use this scanner, the breast eye scanner. Obviously, it's not an ionized scanning machine. It's just it's an infrared ray, so we could do that as frequently as we want, unlike in mammo, which I was going to ask you a question. I will still ask you about mammo. You know, obviously, because of this, we're able to do quite a lot of work around this, but awareness is still key here. We still need to get people to be aware, especially ladies, self-examining themselves. And then if they don't have access to any opportunity for screening, at least that's something that, you know, than waiting till too late and to know what to do after.
Yeah, absolutely. I think before we move, Dr. Femi, just to comment one thing, or 2 points. The first one, the ideal thing, as he said, is the mammogram, ultrasound scan, one-stop clinic, perfect. But that perfect is not always possible. So we need to look at things which are possible, effective, and cheap enough, and reliable enough, and also easy access to the patients. And I think, as you said, the other point is the self-awareness and the examination. I also deal, as I said, with I do some work in Middle East, and again, we deal with patients who have very strong spiritual beliefs, if you want, or whatever you want to call it, with all respect to this, of course. And I always say to them, does your body belong to you in your belief? And majority of them, they say, no, it's all for God. Correct. So if somebody gives you something to look after it, would you look after it properly? Or would you just neglect it? They say, no, I would look after it very good. I said, well, this is the God gift, isn't it? This is God gift, and God gift means that you need to look after it properly. And to look after it properly, you need to ask the specialist. So if you have something, if you have a symptom, you need to ask the specialist. And there's no point of hiding, putting your neck, put your head in the sand. It's not going to go away.
Yeah, sure.
If the cancer is not going to go away, the best thing is to face it, front it, and go early, get diagnosed early, get treated early, and by the will of God, you will live longer.
Yeah. Thank you so much. That's a very strong analogy. I've never thought about it that way, and it's true, because if you're given a gift, you're meant to, to take care of it. And then how do you want to take care of it when you know that there's something wrong and you're just building all this idea in the castle or things like that? So yeah, I like that one.
And the other, even those who don't believe, I would say to them, if you have a car, a piece of metal, and you feel something wrong, would you neglect it, or would you take it to the mechanics? Of course, to the mechanics. You wouldn't neglect it, because neglecting will not make it better, will make it worse. And that's a piece of metal. You're far more important to your body than a piece of metal.
Wow, amazing. Yeah. Great one there. So now I was going to ask you this question. Mammo.
Yeah.
You were talking about, one before and maybe one after and things like that. And you talk about 3 years gap. What I realize with our ladies here, those ones, the affluent ones who have the money, they rather do this mammo every year. They do yearly mammo. So what will you advise in that sphere?
If you look at the studies that have been done and different practices in the developed countries, so you see one every year in America, you see one every 2 years in Canada, and you see one every 3 years in the UK, which makes you wonder which one is the correct. And actually, the fact that they are not the same, that means there's no wrong and right. The 3 years maybe is the minimum that is safe, effective to pick things, especially between the 2 mammograms, to pick things and treat early cancers.
Right.
If the lady has a lot of money, I wouldn't advise going for so many mammograms. Doing mammogram every month is not good. It's going to cause, cancer by itself from the radiation. Once every year, maybe is okay. I think once every 2 years is the best. Right. Person. Not that I work in the UK, but I think the Canadian model is probably, got it right. So it's a balance between, it's not 1 year, it's not 3 years, it's 2 years, or maybe every 18 months, once every 18 months.
Right.
And what I would say, I mean, again, this is my generic advice because I wouldn't know the audience by person to tell them advice specifically. But I would say those who are listening and they live in places where there's no screening program and they have facilities, so they live next to the mammogram machine, let's say, yeah, and there's no problem access, etc. I would probably say, you know, even if there's no screening program, have a screening program yourself. You know, go to the same center once every 2 years, maybe 3 years. 3 years is still safe. One every 3 years, and have a mammogram. Another question, by the way, many people ask, is the mammogram safe? It's radiation, it's, you know, all this x-ray, you know, it's actually safe. And if you look at the radiation that we exposed to as a human walking in the street is measured on a specific unit. And according to that, I'm not going to go through details, but according to that unit, we are all exposed to the cosmic radiation of 2.2 of that unique unit. Doing one mammogram is 0.4. It's like living 7 weeks extra in that year. That's it. So it's not actually unsafe. It is safe to have the mammogram, and it's safe to have that tiny bit of radiation for the sake of the, you know, benefit you're getting out of it. And as I said, if you do it once every 3 years, that tiny bit of radiation is nothing compared to the benefit you're going to get from it.
Right. Wow. Thank you so much. So I hope the viewers are picking one or two things from here. So mammogram is okay. If I think from what we're getting to know, maybe once every 2 years, or maybe once every 18 months, you know, will be good. And the most important thing is, either way, just get yourself checked. Don't wait until things become too bad, and then you can't help it, and then nobody can help in that. I mean, when you get to that stage, so we need to safeguard ourselves, right? So now, self-examination.
Mm-hmm.
I know, do we just a bit about it for us?
Yeah, so a few words about self-examination before I describe what self-examination is.
Yeah.
Number one, some ladies feel very, very anxious about doing the self-examination themselves. They feel like if they examine themselves, they might find something. And they find something, they might find cancer. Now that is exactly the point of the self-examination. You pick things very early. If you do it regular, if you do it every month, then it's unlikely that the cancer, which is, let's say, 5 centimeters, 2 inches, has grown in a month or 2 months. So you're not, you're picking things as early as possible to get treated, as soon as possible. The second point is, again, some ladies feel very anxious. Oh, what if I miss something? Well, if you examine yourself every month, you will know what's new for you or what's your breast tissue looks like. So you will know what's normal for you. And that is the point. You're picking anything which is not normal for you. Your sister's breast examination is different from yours. Your mom's breast is different from yours. Your neighbor's breast is different from yours. There's no one examination for the breast. You will know what is new for you and what is been there for all the time. And it's nothing, just me. That's like a bit thickened here, but that's me. You will know yourself by keep examining yourself. The way you do it, you try, number one, how frequently. You do it ideally once a month. The maximum you can do it once every 2 weeks. Once you start doing more than that, one every day, you're missing the point, because then you start worrying too much and you might actually not picking the new things. The idea is you examine yourself, you forget about it, and then examine yourself at another point and see the difference. Once every 2 weeks, my advice, once every month. Try to avoid the period time so you're not uncomfortable in the breast. Ideally, you can do it whatever you want. You can do it lying down, you can do it standing up, whatever you want. Ideally, in a shower, you put your hand on the top of your head. Yeah. So by doing this, I'm spreading the breast tissue all the way the chest wall. So that breast tissue now can be examined against the hard background, which is the chest wall. Yeah. Don't do this and try to examine yourself that way. You will not pick anything, or you might pick a lot of things which is not relevant. So arms on the top of the head, And then don't do this. Don't pint on the tip of your fingers. It's actually with the belly of your fingers, and try to examine yourself gently from one side to the other. It doesn't matter, left to right, right to left, up to down, down to up. It doesn't matter. It just, you try to examine yourself, and again, the last bit is behind the nipple. While you're there, try to put your hand under the armpit and see if you can feel anything, just gently, very gently. You finish one side, you move to the other side. You do this once every month, maximum once every 2 weeks, ideally once every month. And then you just make sure that you can't feel any lump, you can't feel anything that you're not happy with.
Right.
If you feel anything not happy with, then you take it to the GP or your doctor in your city or in your village, the doctor that you deal with. They will be able to examine you and take it from there.
Right. Thank you so much. That's quite explicit. You're right.
Yeah.
Brilliant. So now a couple of things I want to ask. Okay, let me touch on this first. Well, before we go, COVID-19 had come in and has caused a lot of issues, in the sense that even the structure that we're trying to put in place, for instance, we couldn't go down that route because everybody seems to be at the point of time we're all locked down, and then we had patients to manage the chronic disease management and things like that. We didn't know how to go about it. So everybody is locked down. The last program we did, we picked about 66 ladies that we needed to follow up. And these 66 ladies, they were just thrown in limbo because we didn't know where to go, because we couldn't see them. I mean, obviously we're locked down, and all the chronic disease management was just shut down here. We're still shut down till now. We haven't seen them. We're talking about going to be 3-4 months back now. We're supposed to have followed them up. It's really, kind of appalling, I'll be honest, because where I live is far from where this event happened. So there's even nothing I could do. There's no interstate travel. I'm locked down here, where in Lagos. They're just, hundreds of miles away from me. And there's no, we could just follow them up. So they're there. Some of them have been calling in. It's quite, really, 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 painful, really. Because we picked this lady, some of these ladies, we picked them quite early. And then, so I just want to know, what do you do, like, during this period? How do you manage your chronic cases in the UK, really?
So again, the COVID was, we had the lockdown, we had the issues with not just we not able to function the same way, but also the patients are very worried about coming to the hospitals, and they're very, very worried about coming and picking, coronavirus or anything. And the worry thing is we start seeing a decline in the number of referrals. So if we used to get, 140 something a week for the unit, then we during the COVID, the peak of the COVID, that, less than halved. So, which is worrying, because ladies who develop breast cancer, they will not go away. It's there, sitting somewhere, and they need to be followed up, and they need to be examined, and they need to be, have the treatment, etc. Now, thank goodness that is gone in our unit. We start seeing, ladies coming forward and coming for the one-stop clinic. We haven't by the way, started the screening program. We had to stop the screening program, and it's still stopped from March till now.
Right.
That hopefully will be reopened very soon. But in terms of the cancers itself, we're still seeing and diagnosing breast cancer. Probably, I would say, especially in other specialties, they start seeing more advanced cancer that way, what they normally see. Because you're talking about 2, 3, 4 months delay from in terms of diagnosis and treatment. We're now operating on breast cancers. We have some measures to minimize the risk of having coronavirus, and obviously, actually, you need to put things into context. So, in the UK was hit by the coronavirus harder than maybe Nigeria, or maybe any other country, in terms of the number of patients who got the coronavirus, the mortality rate, etc., etc. So So we had the reason why I need to be very cautious, and we are still very cautious in terms where we operate. So for example, so at the moment we ask all the patients to self-isolate for 2 weeks before the surgery.
Okay.
We do coronavirus testing 2-3 days before the surgery day. They go to the sites where it's clean sites, so there's no patients treated for coronavirus in the same HU, ITU, etc.
Yeah.
And we try to minimize the risk. And so far, I can tell you, we did more than 180 or 70 something, 80 breast cancers in the last 3 months, which is a huge number. And none of them had COVID before or after or during the day. So actually, breast cancer itself, if you follow the guidelines, so like the masks, the self-distancing, of course, it's hard if you're going to do biopsies, etc. But the doctors can be very careful with doing this. And the risk of conducting the coronavirus, if you try to avoid crowded clinics, try to be more organized, have more self-distancing between the patients when they come to the clinics, less number of patients. I think the risk of having coronavirus is small. My worry is if they have breast cancer, this is not going to go away. The breast cancer will not stop for coronavirus and then resume after it goes away. It will carry on doing what it's doing. And that is the worry. And that is the worry. And the worry is if the cancer today needs surgery, maybe a bit of tablets, if not treated today, in 4-6 months, it might not be operable. So you miss the boat. And then you're talking about chemotherapy and more treatment and radiotherapy. You're talking about more treatment rather than having this done today. And it's a balance. So I would probably advise all the ladies who have symptoms or felt something, I advise them here, advise them in the Middle East, advise them in Nigeria to go and still see their doctors. They can do whatever they want. They can wear the mask. They have to be careful, and self-distancing in the clinic. Try to avoid crowded clinics if possible, even if that means waiting outside the clinic. So there are small measures that can be done, can minimize actually the risk of having coronavirus without compromising this cancer treatment pathway.
Thank you so much, Dr. Khout. Now, the other question I was going to ask, I know we're going to round up soon, is the male breast cancer. We've talked about the ladies, and then I think men just believe that they don't have a breast, and then there's no breast cancer around them. But can you help us throw light into this? What are your feeling? Yeah.
Unfortunately, the breast cancer in male does exist. And the myth that the male don't have breasts, that is not true. We actually have exactly same breast like the women. The difference is in the hormones that we have in our bodies, which make the breast in the ladies bigger and the breast in the man most of the time smaller, much smaller. There are benign problems in male, and there are also cancers, breast cancer in male. So men who listen to us, if the most common, of course, is the benign bit of like, big breasted both sides. We call it, a man's boobs, big breast both sides. That is common. But if you feel any hard lump, exactly the same what I said before, stuck to the skin, stuck to the chest wall, the deep muscle, or even nipple discharge, or especially blood discharge, or nipple retraction and lump behind the nipple, please, again, see somebody, because this can be a sign of breast cancer. Now, I have to be honest, if we have 100 of patients with breast cancer, I would expect 99 to be ladies and 1 to be a man, maybe 1 or 2 to be men. So it's not common, but you shouldn't neglect it. And especially in those who are 50 and beyond. So again, I wouldn't expect it in somebody who's 20, 25, unlikely, but don't ignore it. Unlikely, but don't ignore it. But 50 and beyond, I would worry about it exactly the same way I would worry about the, the ladies. So in our unit, we see about 900 cancers a year altogether. I would probably expect 10, maybe 9 to be men. Yeah, so that is about like the 1%, 2% to be, men. And especially in men here, if the man developed breast cancer, they're most likely to be advised to have genetic testing, etc., to see if they carry any breast cancer genes, which we haven't talked about, by the way. So many ladies think if the mum had breast cancer, I should have breast cancer, or what's my risk of having breast cancer? Actually, a family inherited breast cancer is extremely rare. It's not common. So again, in percentage, you're talking about 2 to 3 out of 100 of ladies with breast cancer have inherited genes that propose them to have, or make them more proposed to have a breast cancer. Yeah.
Wow.
97, 98 out of the 100 will have a breast cancer because they will have breast cancer, not because they have. And we start worry when we see a multiple generation in the same family. So, the grandma, the mom, the daughter now, and different age, especially in very young age, breast or ovarian. So again, in the UK, and I think same, you will have like some access in Nigeria to a doctor who can look at your family tree, not from the point of view of inheritance, etc., but from the point of view of diseases and breast cancer distribution in the family, and pick those with probably a higher risk of having inherited breast cancer. Now, I know, for example, let's say in Ashkenazi Jewish population, they have a higher risk of getting this. There are families which, or spots in the world where they're well known for having inherited, or a higher in proportion of inherited, if you want, breast cancer. What we call it BRCA1, BRCA2 gene mutations. And there's new ones, PALB2, which is not very new, but it's been there for years. So the inherited breast cancer is not common. If your mum had breast cancer age 70, doesn't mean you're going to have it. 1 out of 8 in your family will have breast cancer at some point. So count how many female in your family, tens and tens and tens. Some of them will, unfortunately, will have breast cancer statistically. I think still less common in, African countries, maybe Asian, Far East Asian countries compared to the European countries. But the numbers are getting higher everywhere. Yeah. So in Europe, it's getting more common, and in Africa, it's getting more common. And it's more common today than maybe 20 years ago. Maybe because of the awareness. Maybe people had it then and they, didn't notice it. By the way, the first mastectomy described in history was actually during the pharaohs in Egypt. So you're talking about thousands and thousands of years. They described an operation that sounds like they're treating a lump that keep growing in a breast. So it's not a new disease. It's not a new disease. And there are many myths around this, maybe because people are now seeing more cancers than before. So one of the myths, if I put the bra, wearing bra, can make me have a breast cancer, which is not true. And they will say, look in my grandma days, they never had breast cancer. I've never heard my grandma talking about breast cancer. They didn't wear a bra. Well, that is not the reason. That is not because they didn't wear a bra and that we're protected from the breast cancer. Actually, bra has nothing to do with breast cancer or not having breast cancer. The same, by the way, with deodorants and perfumes, has nothing to do with the breast cancer. People try to, so for them, it's still a myth, it's still a mystery, it's still a worry, and they try to have explanation why the numbers are going up. And everyone have his own or her own way of explaining why the cancer is getting up. From a science point of view, it's environment and probably a bit of change in our genes as a human beings, not inherited genes. I'm talking about the effect of pollution on us, all of this, what we call ecogenetic changes. So please, back to the question, male, be careful. If you have a lump which is hard and, especially behind the nipple area, with nipple change or without nipple change, or with nipple discharge or without nipple discharge, stuck to the skin or stuck to the chest wall, please see somebody, see your doctor, because this might be a sign of breast cancer. Not common at all, but you have to be aware, and we do see it in our units and we see it in our clinics.
Okay, thank you so much. So still the breast cancer in male. So in terms of the severity, there's a belief that when a man is struck by breast cancer, it's usually very, very bad. Is that a myth or is that true?
That is a kind of myth, and the reason for that myth is if you compare the male breast cancer to female breast cancer, like for like, yeah. So the same size, the same state of the lymph nodes, the same stage, if you want, is actually not different. The problem is, historically, men are well known for ignoring and neglecting any lumps in their breasts, which is strange because despite the culture, despite religion, despite borders, they're all men exactly the same. They feel something in their breast and they ignore it. Yeah. And unfortunately, because the breast tissue itself is small in volume, it's very easy for the cancer to jump to the armpit or become more advanced in man rather than a woman. But if you compare man with a woman, the same stage, the same level of the cancer, yeah, it's exactly the same in terms of the outcome.
Right. Okay. Wow. Thank you so much. And then carry on.
And the same thing, by the way, for pregnancy. So cancer during pregnancy, breast cancer during pregnancy, again, is well known to be, well, a myth again, is bad for, worse than the breast cancer in non-pregnant. The reason for that, again, if you compare like for like, it's the same. Unfortunately, most of the pregnant women might ignore some lumps because they think this is part of the normal, like, physiological changes. Yeah. Which, if it's hard, very solid, stuck to the chest wall, stuck to the skin, ulcerated, this is not part of the normal. This is breast cancer. This is worried. This worrying to be a breast, suspicious to be breast cancer. So please see somebody. Again, if you compare like for like, they are the same in terms of the outcome. But if you look at how common the ladies to pick something during the pregnancy and say, oh, I'm not worried, I'm not happy with this, I'll take it to my GP, and it turned to be breast cancer, it's unlikely. They're more likely to say, it's nothing, it might be my pregnancy.
Right, thank you. And then during pregnancy, if there's a lump and it's suspicious of malignancy, is it still okay to, post-delivery, is it okay to breastfeed?
It's still okay to breastfeed. It's still okay to breastfeed after even having treatment from breast cancer. It should be fine. Some of the breast cancer treatments might actually make it hard for the lady to breastfeed. So let's say if the surgery needs some kind of operation where they take the nipple area, etc., it'd be hard, of course, to breastfeed in that case. Some of the drugs can, especially if the lady needs to have a chemotherapy, etc., they might actually not be able to conceive and have babies. But that is another talk. That's to talk about, what we do during the pregnancy if there is breast cancer, which is not common. Luckily, it's not common.
Thank you so much, Dr. Khout, and it's been a very, very wonderful time with you. There's been a lot of myths that you bursted there, and there's been a lot of information that even to me they're quite new, and I've really been, informed. So really thank you for the time. Obviously, despite how busy you are, you were able to, to juggle this with us. To the viewers, thank you so much for joining us again. And we look forward to meeting you again during the week next week for another interesting topic. And if you have your questions, you can still drop your questions there. We will be answering the questions as they come in. And then if there are any topics that you want us to discuss that you think would be helpful to you, please feel free to drop them below, and then we'll be picking them one after the other. Thank you so much, and then have a lovely day ahead. Thank you, Dr. Khout.
Thank you very much. Thank you.
You're welcome.